Hello, everyone. Welcome. Welcome to today's session of Oxygen Therapy and Critical Care Case-Based Series. Today is session 11, Essential Emergency and Critical Care. And with us, leading us today, as usual, is Dr. Rachael Kimani and Dr. Eunice. So I'll hand it over to them to get us started.
Thank you, Sarah. Good evening, everyone. I'd like to welcome everyone to today's session. It's our 11th session, so we're almost coming to an end of this series of Oxygen series and critical care. So I want to welcome everyone. Should you have a comment, write it down on the chat box. Should you have a question, you may raise your hand, or you might also write it down in the chat box. So these sessions, for those who are new, are organized by Assist International through Project ECHO and also with the help of Stanford University. So I'll invite Eunice to greet the crowd, and then I can start. Maybe she, okay. Seems like she's probably still offline. So we can start. So today's session is on essential emergency and critical care. So basically this session for today is on aspects towards strengthening emergency and critical care in our various facilities, having policies or having SOPs, standard operating procedures on how to manage essential emergency and critical care. So we have a 61-year-old male who presents to a local emergency room with shortness of breath, dizziness, and diarrhea of 7 days duration. So here are practice change objectives. At the end of the session, we'll explore acute care, critical care, and intensive care, list the domains across which acute care occurs, recognize the critical care continuum, define essential emergency and critical care, recognize two key domains of essential emergency and critical care, identification of critical illness and care of critical illness, determining critical illness using warning signs and scoring systems, improve care for critically ill patients through education and training guidelines and protocols and use of cognitive aids, identify clinical processes needed for essential emergency and critical care, recognize components of hospital readiness needed for EECC, analyze the gap in institutional resources available for critical care, implement EECC and available resources, and of course, advocate for oxygen and additional resources. So this is something that was put up together back in 2021 during the COVID pandemic. So this was just identifying the medical oxygen needs across, and it was noted that all low and middle income countries require 18 million cubic meters of oxygen per day, and that's the estimated cost of that will be $3 billion US. So this was during the COVID pandemic when this survey was done, and it was realized that the LMICs have increased need of oxygen, and at some point, most of the LMICs are not able to meet the need to meet all these needs of oxygen. Let me go down. So you're working in a rural setup. You're working in a rural district hospital. The nearest hospital with an ICU is 40 miles away. The physician working in the emergency room calls you to come see a patient that she wants to admit to the hospital. So the HPI is a 66-year-old man, has 7 days of dizziness and diarrhea. He reports feeling weak. His dyspnea is worse with exertion and better with rest. He received the Janssen vaccine 4 weeks ago. And the vital signs are as follows. Respiratory rate is 27, so this guy is tachypnic. Heart rate is 97, that's okay. Blood pressure is normal, 107/59. Temperature is 37.5. SpO2, he's saturating at 91% of oxygen, on room air, sorry. So he's placed on 3 liters of oxygen and by nasal prongs, and his saturation improves to 95%. So practice change. So what do you want to explore? Explore acute care. What does acute care mean? What does it entail? Explore critical care. When do we say this is critical care and when do you say this is acute care? And what is intensive care? List the domains across which acute care occurs and recognize the critical care continuum. So according to the WHO, what does it define acute care as? So acute care is the immediate care that a patient needs, a patient who's critically ill, or a patient who's deteriorating, or a patient whose vital signs, it could be has specific vital signs that are within out of the normal range, and the patient is at risk of now tipping over to mortality. So it's a patient who is almost like a near miss, and you want to immediately intervene. Can go down. So according to the WHO, it says that this is effective services are responsive to life-threatening emergencies, whereby you have acute exacerbation of chronic illnesses, and these require prompt action. This is time sensitive because immediate action needs to be done immediately, because any loss of a second could lead to loss of the patient or could worsen the condition. You need rapid intervention. There's sudden and often unexpected urgent or emergent episodes of injury and illnesses that can lead to death or disability without rapid intervention. So there is usually an issue of time. So one, the clinician is at a point whereby they need to act immediately, so that now they can sort out the issue that the patient is having, and they can decide how to escalate the patient to the next level of care if the facility is not in a position to offer the continuum of care. Can go down. So time is an issue here. Time is always an issue. So at what point does acute care occur? Acute care can occur in any setup. It can be pre-hospital, before the patient is taken to hospital, in the ambulance, or even at home, where you call the ambulance services to come and sort you out, and sort out the patient, or even take the patient to the next facility that is available. Acute care can happen in the ward, could be the surgical ward, could be in the emergency department, and could also be in a patient who has been in the ICU. Probably patient had improved and then now has tipped over, and you need to act and offer acute care. So the term acute care encompasses a range of clinical healthcare functions, including emergency medicine, trauma care, pre-hospital emergency care, acute care surgery, critical care, urgent care, and short-term inpatient stabilization. Of note is that when you're thinking of acute care, it's a patient who you cannot be able to manage on your own. This is a patient you may require other disciplines to come and help you, or you may require extra help to help you in management of this patient. You're never in a position to manage an acute patient on your own. You can go down, Sarah. So how would you define, just continue, how would you define critical care? Where does critical care occur? How does critical care differ from intensive care? So critical care, if you can go down, it should be seen. So what happens in the critical care? Critical care in a critically ill patient, or a patient who has critical illness. Just mute her. So in a patient who has critical care, critical illness should be seen as just one part of the patient's disease trajectory, and how the patient is managed before and after ICU admission, and has an important role in playing in optimizing outcomes. So this patient is still not yet in the ICU, could be in the ward, but they need to be taken to the facility, to a critical unit. So it could be a patient who has DKA and has deteriorating symptoms. Could be a head injury patient, the GCS is low, and it could be a patient who is septic, causing the ward, maybe it was post-surgical, and the patient has now become septic and requires now immediate intervention by going to an ICU. Why an ICU? What can be done in an ICU that cannot be done in an acute room? We need to know that in an ICU, monitoring is usually minute by minute. So it's a patient who is septic will probably need inotropic support. Inotropic support cannot be done in a setup like in an acute room, because monitoring could be a challenge. Or it's a patient who requires continuous dialysis, that cannot be done in a ward. So you take the patient to ICU. So that is the difference between now critical care and in intensive care. When do you decide that this patient needs to go to the ICU? Can go down. So past medical history now on the same patient that we had. So there's no medical history. Patient states he's otherwise healthy and exercises regularly. He plays football. Past surgical history, there's none. Social history, he's single, lives alone, occasional. He takes occasional alcohol and non-smoker. Medication is none. Allergies is none. He denies hematemesis, melena, and hematochezia. He denies chest pain, no fever. So on your CT scan with contrast, you notice that there's bilateral interstitial pneumonitis pattern consistent with SARS, and there's no pulmonary embolism seen. So what's your plan? You and the emergency department physician decide the patient is to be admitted in the hospital ward with oxygen therapy, can go down, Sarah, antibiotics, and for the community acquired, pneumonia, dexamethasone. Further tests are then taken for workup. Can go down. So this is just to something that the Lancet has put together just to know the global burden of critical illness in adults. This, we can share the link and you can have a look at it later. So which of the following are considered critical patient care? Maybe you can try and answer this. Is it early? One is early recognition, assessment, and decision-making for deteriorating patients, rapid and timely interventions for patients at risk or of clinical decline, identification of clinical warning signs prior to cardiac and respiratory arrest, providing expert assistance in response to concerns for patient status. All of the above are considered. So I can give a second to this as you try and answer. Can keep trying. There are 6 responses and we're 25 attendants, so we can add on. Okay, can end the poll. So majority are towards all of the above. Yes, in critical care, early recognition is important. Timely interventions, because you need to act quickly, so you need to be time sensitive. Identifying warning signs, provide expert assistance in response to concerns. So all of the above are important and considered in the management for critical patients. So we can continue. So what are your practice change objectives here? So we want to define essential, emergency, and critical care. Recognize 2 domains of EECC, identification of critical illness and care of critical illness. Determine critical illness using warning signs and scoring systems. Improve care for critically ill patients through education, training, guidelines and protocols, and use of cognitive aids. So there's something called EEC network. Maybe during your free time, you can just Google it and join the network as well, so that you can understand what the rest of the developed countries are doing to improve on their emergency care and their critical care. So some of the things that they're doing out there, we can try and implement them, and also you can be part of the network. So just Google it and you will see there are a lot of resources in their website, and you'll learn a lot from it. So true or false, critical care and emergency care require expensive technologies and highly skilled healthcare workers. Is it true or false? Let's keep the answers coming. We're giving a second to this. All right, we can end the poll. So it is true, critical care requires technologies and it requires equipment. It's not what you're going to, because in the ward, you probably just need one monitor, but when it comes to the critical care unit, you'll need a monitor for each patient. You'll need a CPR, a resuscitation like bed, a bed that is CPR sensitive. You're able to just press on a button and it gets to the CPR mode and you're able to give your CPR. You will need highly skilled staff. This is where you need critical care nurses. If you're dialyzing, you need renal nurses, you need an intensivist. So you need all the providers, highly skilled providers, to come on board to help in management of the patients. So technologies and highly skilled staff is important when it comes to management of patients, or critically ill patients. We can go down. So this is an example, just go up. So this is an example of how a critical care ward would look like. You can see there's a monitor, there's a bed, there's a trolley, there's the ventilator, which was on the side. So this is not a setup that you'll get in just a general ward. So you need technology, you need equipment that will offer you the services that you require. Okay, we can go down. So what is essential emergency and critical care? So this is something also that's in the BMC, whereby they wrote an article on figuring out the global need for essential emergency care. And they defined it as EECC as care that all critically ill patients should receive in all hospitals in the world. So this network is trying to standardize the critical management that should be available in even LMICs, low middle income countries, and also helping us borrow something from the West. So EECC is a concept that should be a crucial part in the universal health coverage. It is a low cost and appropriate for all countries in all settings of the world. You can go down. So the role of the EECC is to try and standardize it. And what it does, it has set actions and treatments, plus the system-wide requirements and their provision. So it's divided into two key main things. Their domains is identification and care. So identifying critical patient or identifying a patient is critically ill. And then now it emphasizes on the amount of care that you give and the rapidness of the care, or is it the timeliness of the care that you'll give. So it's to identify a case and provide care, hospital readiness, to see whether the hospitals have the necessary infrastructure or the necessary equipment when it comes to management of patients. During this COVID pandemic, we had the opportunity at least of most, or let me not use most, of some of the hospitals getting ventilators through donations, or getting monitors, or getting some sort of help to at least try and improve on the critical care management in our facilities. So it was a good time for our country, because we all know that the number of beds in our country, ICU beds, are still on the low, but during this period, at least the government tried to increase the number of ICU beds that are available. So it's to identify hospitals that are ready for this management of patients. So identification of critical illness, in the identification, can go down. So the patient is sent to the hospital ward. Despite 3 liters of oxygen by nasal cannula, this patient is still having a low SpO2 of 86. So what would you do? If the nasal cannula is still giving you SpO2 of 86, this is when you'd want to escalate to the next available oxygen device. So maybe you'd want to use an non-rebreather mask, you'd want to use an oxygen mask, or you'd want to also use a nasopharyngeal device to offer the oxygen. So this is an example of identification of critical illness. What is the clinical problem identified? And then who is responsible for identifying this problem? So it's usually the clinician, me and you, the clinician, identifies that this patient is probably dyspneic. This patient has high respiratory rate. The patient probably has a high pulse rate. The patient is maybe using muscles of accessory muscles for breathing. So meaning they're tachypneic and they're struggling for breath. So it is the clinician, the medical officer or the consultant who will identify that the patient has a problem. So what is needed to identify the problem? Most of the time, physical examination is always emphasized in in diagnosing or in assessing a patient, not immediately going to the lab works and all. You always want to first do a physical examination. Then from the physical examination, you decide what should happen next. So whatever the case is, maybe you'll want to escalate the level of care in terms of the oxygen that you're giving. Probably you're thinking of maybe giving ionotropes. If the patient was hypovolemic, you want to give fluids. So once you identify the problem is down there, you decide what should happen next in management of that critical patient. So we can go down. Should you have a question, just ask as we go along. The ward nurse calls you when you arrive the hospital. When you arrive, the patient is alert but appears to be breathing harder, and he can only speak 2 to 3 words at a time. So we can see his saturation is at 27, his respiration is at 27, he's a febrile, heart rate is still fine, blood pressure is fine, but SpO2 is low. So can go down. What is an example of hospital system that serves to identify deteriorating patients before they become critically ill? So basically here we are trying to understand, does your facility code patients? Is there a coding of the type of coding to show this patient is coded, meaning that they're critically ill? So most hospitals use like code blue. So you'll code the patient and say, yes, this patient needs urgent care, so that in case these patients are coming in through the casualty, when they're in casualty, you're able to identify them quickly and offer the care instead of having them queue through the whole process of admission. So once you code the patients, or once you have the team that usually codes the patient, the next thing is to have a rapid response team. So in facilities that are well and facilities that are organized, what happens is during every shift in the ED, emergency department, you'll have a team that has been identified as the rapid response team. And this is a team that usually now manages the patient who is coded and immediately identifies the level of care that they need. This tries to save time and also tries to narrow down on the care that the patient will give, and it will then determine where you'll take the patient. And this rapid response team should be a team that is trained in ACLS, BLS, probably also have ETAT, EPALS. So it's a team that is able to work immediately should a patient need resuscitation, or a team that is conversant in management of critical care. It could also, these setups could also happen in the pre-hospital setup. Even in the pre-kind of hospital, that is before the patient gets to the hospital, the ambulance team should also be well trained and should also be able to act immediately. We can go down. So list at least 3 warning signs that patients may exhibit prior to deterioration. So this we all know, because in the other previous sessions, we were talking about this in the previous sessions. So what are the warning signs? These are the clinical signs that you'll identify with the patient. So you go system by system. What is in the respiratory system? How is the respiratory system? Are they tachypneic? Are they using accessory muscles? What is in the CVS system? Is this patient bleeding? Is this patient pale? How are the BPs? Is he hypotensive? How is the heart rate? How is, once you do the ECG, are we having signs of MI, or are you having issues like sinus venous, supraventricular tachycardia? Then you go to the other system. You also check the CNS. What is the GCS of this patient? How is this patient doing? What is other additional things is, what is the saturation? How are the vitals? So all this, which she has highlighted, is what will tell you when the patient is deteriorating. Is there a seizure? Is there some sort of uncontrolled pain? Are we losing blood? Is the patient bleeding? How is the urine output? Are we having AKI? And if we're having AKI, how is the output? Can you quantify it? So all these are signs of deterioration. What is Muse 2 and when should it be used? What is Muse score for the patient? All these scores, it's national early warning signs. They keep changing, so they're different scores, but at the end of the day, the aim is the same, to try and identify how is the patient scoring. You don't need to cram this. This is available online. So you just go to the online page, key in various parameters. So you want to check how is the respiratory rate. So for instance, if the rate is between 12 and 20, you give a score of 0. Is the patient having hypercapnic respiratory failure? You say yes or no. The room air, are they on room air? How is the SpO2? They're all those scores. The temperature, how is the blood pressure? So basically it's the vital signs that it uses to categorize whether this patient is, to give you a score of the patient. How is the pulse rate? There's a score. What is the level of consciousness? Are they alert? Is the patient COVID suspected? Is it likely or confirmed? So at the end of it all, it gives you a score, and the total amount of points is 10 points. So you're able to know the risk, the high risk patient, and the one that requires continuous monitoring. The different scores, you don't need to scrum this. It's available online. We'll share the link. So care for critical illness. You decide to increase the patient's oxygen therapy by switching to a mask with a bag and non-rebreather, and increase by 15 liters per minute. Remember, this patient was saturating at 86% and was on 3 liters of oxygen. So once you increase, the amount of oxygen and you've changed the delivery device, you now want to, of course, you'd expect at least there's some improvement. So you can continue. This is an example of care of critical illness. How do providers know how to give the appropriate care? So we learn from different platforms. So providers will learn from different platforms. It could be educational, where you have your continuous medical examination, education CMEs in your department, or it could be the online CMEs. It could be through reading. It could be through other various resources. So you learn from these devices or from these forums to identify and know what to do in such a situation. Also, there are trainings available. There's the base BLS, ACLS. There's also courses that are there available for emergency training, emergency management. So these courses will improve on your knowledge. Can go down. So there are also guidelines, critical care guidelines and protocols. Different countries have different guidelines. So in our country, at least, we've identified the COVID protocols, and we also have guidelines in critical care management. There are different types of things and protocols available. So these are some of the ones that are available online. You could have a look at it. So true or false, during the stress of a critical event, physicians are more likely to implement all known best practices optimally. Is that true or false? Some people are saying false. I don't think this answer really has a definitive answer, because at times during the critical care, when you're under stress, you might not be able to implement everything, but with time, once you gather your thoughts, you'll be able to implement all that you can. But it is at best practice to always implement everything that is known of the clinician or the physician. So they're able to implement all guidelines and all practices that they want for the benefit of this patient. So majority has said true, which yes, but even at the false could be somehow, they could also have a point. So we can end the poll. Okay. So during the stress of a critical event, the vast majority of clinicians do not implement all known best practices. This is a study that was done, and this is what they identified, that most of the clinicians are not able to implement everything optimally. I'll go down. So this is just a Stanford Anesthesia Cognitive Aid Group. It's just an example of how various facilities also have manuals. We can continue. And these manuals help you in managing the patient. So this is also a type of a manual whereby you have what to do when you have decaying pregnancy. It gives you guidelines that are straightforward and they're point to point, and saves you, at least helps you manage the patient as well, in case you do not remember maybe the dosages, in case you do not remember the lab ranges. So with these guidelines, it helps you. Can go down. So practice change objectives. So we want to list the clinical processes needed to identify and care for critical patients, recognize components of hospital readiness needed for EECC. So here we want to try and conceptualize this EECC, essential emergency critical care. So discuss how EECC works in practice. I don't know if someone is ready to say something about their facility, on how their critical unit works, or how they manage critical care patients. Anyone? Okay, maybe I can talk about my facility. So what happens, I work in Bagathi. So what happens in Bagathi, we've implemented the coding system in our casualty. So when a critical patient is seen in the triage, they are coded. But of course, at times the challenge is maybe the queues are too long. So you're probably not able to identify them quickly, because we usually see a lot of patients, but we always try and ensure that these patients are coded. And there's always a team in the acute room that will rapidly manage these patients and will be timely in the management of these patients. We could go down. So this is in the ideal setup. So it just shows the global need for essential emergency and critical care. So what happens is there hospital readiness? If the hospital is ready, what's the clinical practice? Who is looking at these patients? Who is identifying these patients? Once you identify, is there essential care? Do you have everything that is required? The medication, the equipment, the facilities? How effective is the coverage of the EECC? How do we stabilize these patients? What is the survival rate of these critical care patients? So having a diagram, or understanding the flow of events in your facility, and then assessing or having audits of these patients, you're trying to assess morbidity and mortality. It helps to improve, or helps you identify the gaps that the unit could be having. And once you identify the gaps, you always want to improve the care. So we could go down. The elements of essential emergency and critical care. So this is just almost what I was trying to say. What is the triage like? What is the structure? What is the clinical process? What facilities do you have? Do you have trained staff? Do you have guidelines? Do you have oxygen? Are there emergency drugs and equipment? And then the clinical process needed for essential care. Is there appropriate use of airway actions? Is there appropriate use of oxygen? Is there oxygen available? Is there appropriate use of IV fluids? Do we know the dosages? Do we know how to give them? Do you know whether to give ringers or not, or whether to give normal saline? You can go down. So basically, then after you've given the care, you have the desired outcome. So just to add on to something, in this EECC network, they have partnered with various people and various organizations. So they have partners in health, they have Yale, and they have identified essential emergency and critical care, a consensus of global experts. So you could have a look at this article. So in your free time, this is an article that is trying to understand critical care across various countries. And at the end of it all, it's to try and improve management of critically ill patients. Could go back. So list the clinical processes for identification of critical illness. So we had said, this is just a recap. So you identify them through physical examination. Can go down. So you're looking at the pulse rate, blood pressure, respiratory rate, oxygen, temperature, level of consciousness. Then once you identify, what happens when this patient arrives at the facility, who takes care of the patient? If the patient needs urgent surgery, what is the gap in timing? How much time is lost by the time diagnosis is made and taken and the patient is taken to theater? Is there a requirement of this patient once in theater or once done? How was it during surgery? Was there any critical event? Does this patient require ICU post-surgery? And then the follow-up and re-evaluation of this patient. Can go down. So when it comes to care basically means, are we optimizing these patients well? Are we managing the airway? Have you noticed whether you have a blocked or threatened airway? What are we doing about it? Do we have secretions? Are we suctioning? Is there a foreign body? Have we removed the foreign body? Is the patient able to, is the airway patent, or is the patient able to maintain their own airway? And what are we doing? There's also breathing. Do you need nasal prongs? Do you need bag mask ventilation? How are we going to manage this patient? Can go down. Most of these things we know, so it's just a recap. When it comes to circulation, have we stopped the bleeding? Are we giving ionotropes? If it's reduced level of consciousness, are we going to take to ICU? What is a GCS? Is it due because of, maybe it could be an epidural hematoma. So if it's an epidural hematoma, can you take the patient immediately to theater and sort it out? List the elements of hospital readiness needed for identification. So what do you need to identify these patients? We can go down. So of course you need equipment. You need the pulse oximeters, you need the probes, you need the blood pressure machine, you need the blood pressure cuffs, you need a light source, you need a thermometer. You need consumables. Do you have examination gloves? You need drugs. You need the human resources. You need trained staff. So you need to keep having trainings. It doesn't have to be trainings that are always organized outside the facility. You can have on-job trainings. What are the routines? What are the guidelines? And what's the infrastructure like in your facility? Is there running water? Is there a department of emergency unit? Do you have an intensivist? Do you have an anesthesiologist to help you should you want to intubate this patient and sort out their airway? Can go down. So what equipment do you have? Do you have the suction machine? Do you have the flow meter? Do you have the bag valve masks? Do you have the oxygen delivery devices? Do you have a ventilator? Do you have monitors? So all this is now for the hospital to sit down and see what they don't have and what they have and what is the need. And go down. So there are all those things which are required in a facility: drugs, human resources, training, routines, guidelines, and infrastructure. It's almost the same thing that I was saying. So can go down. Just go down. This is just a monitor showing you. This is a ventilator, just showing you what to do. So list the general processes supporting EECC. Yeah. So what are the processes that are supporting this EECC? Care is provided according to the general processes. So you have assistance from additional senior staff. You have a place whereby it's centered and you've said this is a critical unit, this is what happens, and this is how it happens. You have the IPC. What are the IPC measures? Infection prevention and control measures in the facility. Is the communication clear? Is there verbal communication? Is there visible coding? Is the patient, EECC is provided without considering the patient's ability to pay. So you always have to provide care for a critical patient, even if they are not able to pay. What you need first is to save the patient, then sort out payments later. Documentation of notes. Have you documented well? Is there effective communication with the family? You have to keep informing the patient, the family, on every step that you're making in a critical patient. So at least you keep them on the know-how. Continue. If there's a poor resource to treatment, is there available treatment? What are the clinical processes are discontinued or no longer there? It is to recognize when EECC alone is not sufficient to manage critical illness. And then at the end of it all, we reevaluate and see, have we improved? Do we need any definitive treatment? Do we have any investigations to add? You can go down. This I'd already talked about in the clinical signs. You can go down, Sarah. So list additional elements of ECC needed for care in the COVID patients. So of course, in the COVID patients here, we needed the PPEs, we needed heparin to anticoagulate, we needed steroids, then antibiotics were used, and also there was the monitoring of the patients. Were the hospitals ready? This I will not go into because anyway, I think we are past the COVID, but during that COVID period, hospitals were at least equipped to be slightly ready and to have the equipment that is needed. You can go down. I hope I'm not too fast. In case you have any question, you can ask me. Just continue. This is already said in the other one. So practice change. So here we want to analyze the gap in institutions, in institutional resources available for critical care, implement EECC for available resources and advocate for oxygen and additional EECC. So once you identify the gaps, what will happen? You try and figure out how to solve out on these gaps and figure out how to sort out the gaps in the facility. So how do you identify? Go down. So you identify your gaps and identify your goals. So identifying the gaps for each of the following. So it could be gaps in the sense of space, staff, systems. So you identify, do we need now to add more staff? Do we need to identify more space to at least have more beds available? And then you have action plans. So there's something called SBA and SWOT for each action plan. So SBA means, can go down. SBA means, is it the next thing? Just continue. You can continue down, just to explain SBA. So SBA is situations, to identify the situation. For instance, the situation is lack of, the patient needs oxygen and maybe there was no available oxygen. What is the background? How have you assessed the facility? Does the facility have the capability of providing oxygen or having the oxygen cylinders? Does the facility have the flow meters? If not, now this is where you give recommendations. You go to the authorities and tell them, yes, we need more flow meters because we have more patients coming in as acutely ill, and we're not able to provide them with the oxygen that they require. So you offer the recommendations. You probably need more ventilators, or you need more staffing in the facility. So you analyze the situation, understand the situation, and then you give recommendations. That's what SBA means. Then there's something called SWOT analysis. You can go down. So in SWOT analysis as well, you identify the strengths, weaknesses, opportunities, and threats. What are the strengths of the facilities? What are the strengths of the people offering healthcare, the critical care? What are their weaknesses? Are they understaffed? Do they have adequate training? What opportunities can we give them? Can we offer them more training? Can we help them? Can we increase their staffing? So you then analyze that each situation, and at the end of it all, you come up with something that will help improve the care of the patients. So at the end of this, so what are your practice change objectives? So in each facility, at this point, we should be able, if in case you don't have a department or physicians that have identified or are trying to identify the acute room or the critical care room, or even how to manage the critical patients, we want to define acute care, critical care, and intensive care. List the domains across which acute care occurs. Explore the critical care continuum. Define EECC. List the two key domains of EEC, which was identification and care. What are the warning signs? How are we improving care through training, guidelines, protocols? List the clinical processes needed. Recognize components of hospital readiness needed for EECC. Analyze the gap in institution resources. Implement EECC and advocate for oxygen and other additional resources. So at the end of this session, these are some of the things. Now when you go back to your facility, you sit down and see how to improve care, how to ensure that you have an essential emergency and critical care available. Can go down. So we expect you to do what you can, where you are, with what you have. whatever resources you have, make do with them, but always aim at improving and offering better solutions or better care for our patients every day. I think I have come to an end. Could that be a question? Today's was more of protocols and what to do next after because previously we were doing clinical setups. Now, once we've known how to identify patients, now let's put systems working so that we can be able to manage the patients. Any question or any comment? Since there's no question, I think we can come to an end of this session. So once again, I want to say thank you so much for being part of today's session. It was a great honor to have you on board. It's my prayer that at least we are getting to learn something, or we're getting to improve on our critical care management. At the end of this, it's to at least improve our critical care. That is the point in these sessions, and to improve availability of care for our patients, and to also, as a facility, to sit down and reflect what needs to be done and what needs to change. So today was the 11th session. Next month will be our last session. We've done 12 sessions for this critical care series. And I want to say a special thanks to the people who put it together, that is Project ECHO, Assist International, and Stanford. Thank you for this opportunity. And I'm so sure that everyone would say that they have gotten something out of it. So Sarah will share the link on where to get these sessions online. It's available on the Stanford Medicine website. It's available, and you could have a look at it during your free time. So thank you once again. I don't know if Sarah has anything to say before we wrap it up.
No, thank you, Dr. Rachael, for a very informative session. It was excellent. And we will see you all next month for our next session.
Okay. Thank you so much. Have a lovely evening. Bye-bye.
Good
night. Bye.